Thank you. I'd also like to start with saying that it's been a great pleasure and honor to be part of the task force, and it's also a great honor to be presenting part of the guidelines today. I'm going to talk about long-term or longer-term therapies, since the start of these, some of these therapies are not really very long-term. These are my declarations. Firstly, logistical issues for hospital stay. I'm going to focus mainly on the changes that have been implemented in comparison with the previous guidelines. But as previously, it indicated that all hospitals participating in the care of STEMI patients should be equipped to provide the appropriate treatment. And we have changed, we've become more confident with these patients, that we now recommend that transfer from a PCI, the primary PCI hospital to non-PCI hospital can now be on the same day, and because of this confidence, we've changed it from a 2B to a 2A recommendation. We feel confident that this is safe, although it's based on expert opinion. Monitoring during the hospital, it's indicated that STEMI patients are monitored for some time, and this is unchanged in comparison with the previous guidelines. But similar to the transfer from the PCI hospital to non-PCI hospital, the hospital discharge, we also feel more confident that the patient can now be discharged. In an uncomplicated patient, the discharge could be already within 48 to 72 hours. We've upgraded this from 2B to 2A, and because there's also evidence, this increased evidence since the last guidelines, we've also upgraded the level of evidence from B to A. Behavioral aspects after ST elevation myocardial infarction have also been changed slightly. Of course, it's pivotal to help the patient to stop smoking. We've upgraded this recommendation from 1B to 1A, but also changed the wording to include that we should help the patient supporting with nicotine replacement therapies, varenicline, bupropion, individually or in combination, because these are evidence-based medication to help people to stop smoking. Participation in a cardiac rehabilitation program was also recommended previously, but we have upgraded in line with the prevention guidelines from 1B to 1A based on the evidence base. We have added, as already mentioned by Stefan, a new recommendation on the polypill. The use of the polypill and the combination therapy to increase adherence to drug therapy may be considered. This is a new recommendation. It's based on several studies, but mainly this focus study published in 2014, in which it was shown in post-MI patients that the use of a polypill increases adherence to medication at 9 months follow-up. Of course, not all countries have polypills available, but it should be, you may consider using this if it is available. We also address lifestyle intervention, potentially the most important intervention with regard to improving prognosis of the patients. I'm not going to get more into this, but we have dedicated chapters on each of these topics, and they are in line with the ESC prevention guidelines that came out last year. Routine medical therapies, first the beta blockers. We have not changed these, although the routine use of beta blocker is mainly based on older studies. In the pre-reperfusion era, there's no new evidence come out, so we have not changed the recommendations for the beta blockers. We have changed, or we have omitted the previous recommendation on verapamil, which we previously recommended, but it was based on only one study. One trial, which was published in 1990. Use of verapamil can still be appropriate for patients without heart failure in whom a beta blocker is contraindicated, but we have chosen to take it out of the recommendations to not put too much emphasis on this. Lipid-lowering therapies. we still recommend that you start with a high-intensity statin therapy as early as possible and maintain it long-term. This is unchanged. It has a 1A recommendation. We have updated the goal for lipid-lowering therapy. The LDL-C goal is now 1.8, as you know, and with the option of being even more aggressive, if the starting point of the LDL-C is below 3.5, you may go for a 50% reduction in the LDL-C. This is in line with the prevention and the lipid guidelines from 2016. It's still recommended to obtain the lipid profile in all STEMI patients as soon as possible after presentation, but we no longer require that this should be fasting, and this is based on the fact that there's very little difference between fasting and non-fasting lipids, and for logistic reasons this will be to be preferred. Finally, we've added a new recommendation based on recent trials, that in patients with LDL-C above 1.8, despite the maximally tolerated statin dose, who remain at high risk, and we have not defined precisely what high risk is, but further therapy to reduce LDL-C should be considered. And this is based, of course, on the Fourier trial, published earlier this year, showing significant effect of PCSK9 inhibition on cardiovascular outcomes, although not on mortality, and similar results from the Improve It trial published in 2015, in which the addition of ezetimibe to simvastatin also improved cardiovascular outcomes. The recommendations regarding ACE inhibition and ARBs and MRAs, they have not been changed. The wording has been changed just a little bit to be in agreement with the 2016 ESC heart failure guidelines. For long-term management of ventricular arrhythmias and risk evaluation for sudden death, these are also in agreement with the heart failure guidelines, and of course focus on identifying patients in need of a prophylactic ICD. Maintenance antithrombotic strategy after ST elevation myocardial infarction. We have a number of class 1 recommendations, but these are also dealt with in detail in the focused update on dual antiplatelet therapy, also presented at this conference. So I'm just going to briefly mention a few of them. The changes in comparison with the last guidelines are that PPI in combination with dual antiplatelet therapy is now recommended in patients at high risk of gastrointestinal bleeding. This was also recommended previously, but we have upgraded from 2AC to 1B. Class 2A recommendations regarding the maintenance antithrombotic strategy. These are, as you can see, not based on strong evidence, but these are prudent considerations from the expert group that to be careful when you're weighing the risk versus the risk of bleeding versus the risk of recurrent events. Class 2B and 3 recommendations for maintenance antithrombotic strategy. There's one new recommendation here based on the Pegasus TIMI 54 trial in that high-risk ischemic risk patient, in high ischemic risk patients who've tolerated dual antiplatelet therapy without a bleeding complication. Treatment with DAPT in the form of ticagrelor, 60 milligrams twice a day on top of aspirin for longer than 12 months may be considered up to 3 years. And this is based on the Pegasus TIMI 54 trial, showing these reductions in events. For patients on oral anticoagulation, there are 3 specific recommendations in patients with an indication for oral anticoagulation. These are indicated in addition to antiplatelet therapy for the 1C recommendation. In STEMI patients with stent implantation and an indication for oral anticoagulation, triple therapy should be considered only for 1 to 6 months, according to a balance between risk of coronary events and bleeding. And the use of ticagrelor and prasugrel is not recommended as part of a triple antithrombotic therapy, as 3C recommendation. We have tables for specific dosage in chronic kidney disease. These are more tables than the one shown here. We have recommendations regarding, a new recommendation regarding routine use of echo after hospital, hospital discharge. We have routine use of, we recommend new echo performed between 6 and 12 weeks after the myocardial infarction in patients with a left ventricular ejection fraction below 40 to make sure that these patients are or are not candidates for ICD implantation. And also we upgrade the use of MR when echo is not sufficient to provide the imaging that we need. So finally, there were 3 new recommendations in long-term therapy: additional lipid-lowering therapy in high-risk individuals who still have LDL above 1.8, extension of ticagrelor, and use of the polypill. And again, you can, for the flowchart for ease of following the various recommendations. So thank you very much for your attention.
Thank you very much, Eva.